Welcome, everyone, to today's webinar, How to Prepare and Create Capacity for COVID-19, Actions to Free Up Beds, Vents, and Staff Now. I am Brian Zimmerman with Becker's Hospital Review. Today's webinar will consist of a presentation and 2 question and answer sessions. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We're looking forward to hearing your questions. We will also have 2 audience polling questions during the webinar. We appreciate your participation there. There will also be a live demo during the webinar, so please make sure your media player is open and functioning. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. It's my pleasure to start today's webinar by introducing our presenter. Mudit Garg is the CEO and co-founder of Qventus. The Qventus platform uses machine learning and behavioral science to automate patient flow and transform operations for leading health systems across the country, including academic, community, and safety net hospitals. Prior to Qventus, Mudit co-founded multiple technology companies, including Vidopia and Hive. He also spent time in McKinsey & Company's healthcare practice, helping large providers with organizational transformation and performance improvement. Mudit has been recognized for leadership as one of Silicon Valley Business Journal 40 Under 40. He is a Stanford StartX mentor. He earned a master's in business administration and electrical engineering from Stanford University and a bachelor's degree from the Indian Institute of Technology. At this time, I'm pleased to turn the floor over to Mudit to begin today's presentation.
Good morning, and thank you, Brian. Thank you, everyone, for taking the time today to let us share some of the ways we are working with our customers to both prepare for and create capacity for COVID-19. I know it's an uncharted time for all of us, but we hope that this knowledge helps each of us prepare and be better situated for the COVID-19 pandemic. I think Brian shared a little bit about us. We are a company that uses AI and machine learning in real time to help over 120 deployments across the country in managing patient flow and operations, and very specifically creating capacity in a way that doesn't increase workforce staff on a day-to-day basis. We've seen really transformative results in doing so across the customer base, in things like reducing length of stay and creating extra 40 to 50 beds a hospital. By doing so, reducing the ED length of stay, improving the OR flow as well. And through that, being able to really help the front lines and increase the value of the investments and data that sits in the EMR. But it's as you all know, it's a pretty unusual time that we are going through right now. We have all been making some significant efforts to look at the pandemic and find ways of flattening the curve, because it's pretty clear if we don't, we run out of capacity fairly quickly. While those efforts have started to show early signs of promise, if we are successful, we are likely to not have sufficient capacity to be able to meet the demand of the pandemic. So what we've been doing and thinking through with a lot of health system partners is how to create virtual capacity, a really highly coordinated flow, and a plan for that surge in a way that we can actually take care of these patients as they come through the health systems. And it is even more challenging to do so in an environment that we have already taxing our healthcare workers, where they have limited availability given possibility of infections and difficulties with childcare and other pieces as well. So as much of that capacity as we can create through virtual means, it is even more compelling and important to act on right now. So the way most of our health system partners are right now preparing for and thinking about COVID-19 is in a few different phases. First, right now, is to really think through and have a strong way of predicting the various aspects of the surge. So we'll spend a little bit of time going through how to best predict and plan for that, the variability and the unknown information surrounding that, and how to sort of build the best assumptions to get the best answer. The next first capacity point is likely to be around ICU and vents. And we have, we'll talk a little bit about what organizations are doing to manage that. The next area is, you can think of it as either physical bed capacity, but more importantly, actually the staff capacity, given the nursing staff and other staff taking care of these more sick patients will be needed at higher proportions. Alleviating med-surg capacity and creating space from a staffing standpoint will be super critical sometime around late April. We will still have a surge that we have to figure out how to manage in the middle time, and or if this does have a lull in the summer due to low transmission with heat, then I think we may end up in a situation where there is a second peak or a third peak late in the fall, both due to the COVID-19 itself, the flu season interacting with it, but also potentially all the rescheduled surgeries and electives coming back at that point in time. So that's the different phases in which organizations are currently thinking through and preparing for this. So let's actually go through 4 things as we go through today. One, will start by how do you create the best planning for these surges through localized COVID-19 planning models that we will share and explain. The second is how to create and manage capacity in the short term. Third, what to do ahead of the potential follow-on surges in fall and later to be in as strong a position as possible before that. And then we'll leave hopefully plenty of time for Q&A at the end as well. So the first thing that I think we've shared, we have started by helping customers have an ability to understand what the effect of COVID-19 in their localized market and for their specific hospitals would be. As we did this work, it was clear that there were some mechanistic models around epidemiological models that are beneficial, but initializing them and keeping them up to date and then creating mechanisms where a user can understand the assumptions and the effect of the assumptions was a fair amount of work and would be incredibly valuable and beneficial to organizations across the country. So we've actually taken that part of the product and made it pro bono and made it available and free for anyone to use. Any organizations or the general public can go to the website and the link linked in here, Qventus.com/COVID-19-model, register there and be able to use that. What this is doing is we've created a set of about 450 localized epidemiological models, and we are updating them continuously as more and more data is coming through to make sure the assumptions and the models are fitting as well to the local areas as possible. This is super critical because the amount of information on this disease, being given how novel it is continually changing. And to keep those models up to date and up to date at a localized level was pretty critical to getting a good answer for organizations to be able to plan around. Secondly, what it specifically does is identifies capacity constraints around med-surg beds, ICU beds, ventilators, and PPE resources. And in addition, helps you understand what the risk of several different scenarios like increased or decreased social distancing, PPE conservation, the effect of hospital staff infections might be. So I'll walk you through all that in a second. The way this works is it populates demographic data for each individualized local area automatically, the various age cohorts, the understanding of the risk of infection, risk of hospitalization, critical hospitalization, and pulls all that together along with the best available starting points of hospital resource estimates in every area. What we are also doing here is we are using what's called the Dartmouth Atlas Hospital Referral Region. Since you know, certainly while the model is running at a zip code level and pulling data for population at a zip code level, the healthcare consumed and the demand and supply of healthcare is not contained within a zip code and often not contained within a county either. So what we've done is used work that the Dartmouth Atlas project have done to define regions that are called the hospital referral regions, which is typical areas within which the population is willing to travel. So especially if we end up having, sorry, just saw a message that we may have lost audio, especially as we end up having a situation where we are overwhelmed, the ability to be able to use to be able to counterbalance the supply and demand within an area is super critical to us to not get the false results. There are three assumptions that are pretty critical here, which we'll walk through: doubling time, how quickly the disease is doubling, percent of infections that are actually being reported, and the third is what level of social distancing is practiced and how effective that is. So let me actually take an example and switch to the model here really quick. So what you see, first of all, when you open this URL and after you register is an ability to add one or multiple hospitals in here. So for example, if I was to take, let's say Minneapolis, I was to take a hospital called Southdale, another hospital called Ridges, right? So I took these two hospitals, and I might also want to take another hospital from the same system that is close to them. So you can do multiple hospitals across multiple areas, in short. So you can see these were from Minneapolis, these are from St. Paul, and let's say I want to take one of the hospitals from St. Paul as well. So you can start seeing that the model is automatically pulling in the number of cases that are happening in those local areas, the population of those local areas, and the rate at which the cases are growing. You can also take in and modify any assumptions that you don't feel are appropriate. So for example, you can in here modify known cases or population or the market share. You can also, one of the areas that there is sometimes mixed data is the initial information around med-surg beds, adult ICU beds, and vent. So we've taken that information from existing public sources, but you can modify those as well. And then lastly, and what's pretty critical to understand, are using the demographics of your local area. We are computing specific non-critical, critical care, and critical care with vent rates that we are likely to see in your area. And we are also using research at estimating the length of stay for these different types of patients. Then the model initializes doubling time by looking at the rate of infected patients growing in your area, but also more importantly, the percent of cases that are typically underreported in your area, and use a set of those assumptions to initialize how quickly we think it might increase, what percent of infections are being reported, and you can use that to then run the model and see how many new COVID-19 patients would you see in the next 7 days. Both non-critical, critical patients, and critical patients requiring vent. You can see days until capacity is reached, which for this Minneapolis region and these hospitals in particular, they have a little bit of time. You can see specific day-by-day predictions and projections for the med-surg patients, ICU patients, and patients requiring ventilators. You can also see what PPE-equipped nursing staff might you need at any given point in time, and what cumulative PPE nursing shifts might you use. So that if you know, for example, that on average we are using about 2 N95 masks a nursing shift, you can roughly compute that by 4/24, for example, I would need 2,000 masks by that time. So those are the outputs of the model that allow you to get an understanding of what's going on. You can also see all the assumptions about the model in this model methodology tab that is on the top right. You can download the results of the model through the export data button. And if you make any changes and let's say you update the bed capacity or what you expect your surge capacity to be, you can take the URL through this link button on the top right, copy the URL, and be able to then bookmark it and just have the same starting point in the future, or share it with others so that they can have the same starting point as you as well. So those are the basic mechanics of the model. We've backtested the model across several states and see usually within about 10 to 15% of the admits, so about 85 to 90% of actual admits predicted. We are spot on with that. And we've seen that it's actually been fairly beneficial to continually update the model as that goes along. The next piece I'll walk through is the scenarios and mitigations. we heard a lot from the customers and partners that it was important first, given the sensitivity of assumptions, that all the assumptions were exposed to users so they can play with it and they can get a chance to see how they affect the model and its predictions. So we've done a lot of that, but also modeled in some scenarios. So if you believe you're in an area where there is likely to be additional social distancing than what is being seen so far in the data, then you can add that in. And what that'll do is actually slow the transmission of the disease down even further. Right? So you can update that and see that the disease transmission will be slowed down even further. You also have the ability to, this is also done in most areas already, but to factor in if you hadn't canceled elective surgeries and you want to cancel elective surgeries now, what happens with that? Similarly, you have the ability of seeing what happens with improved flow, what happens if a certain percentage of hospital workers are infected and therefore are not able to, you don't have staffing available. What happens if you go into a PPE conservation mode where you start using less PPE, personal protective equipment, but as a result, the infection risk of staff increases. And lastly, what's turned on by default is that when you run out of ventilators and you have to start triaging people going into ICUs and getting to use ventilators, that there is likely to be a mortality multiplier, and that is set by default at 1.5x as well. These assumptions, almost all of them are listed out in this methodology document that you will see, and those assumptions also allow for the sources that you can check and get a chance to read through as well. So I'll share a little bit about how to use this model. The way health systems have used it most is the first, to understand that the model gives you a very intelligent set of defaults about your area. But we do understand that you may have much better local information. So they are testing that with local information to see what assumptions to change. Second is to plan for scenarios and for a range of outcomes based on that. And I think last is to have understanding in their COVID incident response centers about what plan is likely to be needed for the upcoming next week. There are some limitations to all these models, as I was describing before. There's actually a New York Times 538 article this morning about why it's so freaking hard to make a good COVID-19 model. If you look at it and if you understand, if the reason is, A, it's a very novel virus and many aspects of the disease and its transmission are unknown. There are some assumptions around the doubling time, or what's often referred to similarly as R0, which is the rate at which transmission happens. So let's say if I was infected, how many other people am I likely to get infected? Both given how infectious the disease is, and also depends on how many people do I get in contact with. So what is that rate? So as you can see that if you reduce how many people we get in contact with, that rate will reduce. The second thing that is pretty critical is what percentage of infected cases are actually getting reported. And there are a multiple set of reasons why this number might not be what 100%. Right. The first is that without sufficient testing, we have not had enough testing to actually get a full understanding of everyone who's infected, and we've tended to test more people showing severe symptoms. And the second is our testing takes some time to get that to get confirmed as well. So for both of those reasons, the actual infected population is less than what is reported as well. And then the last piece I would say is the long-range effects of social distancing aren't very well understood. What happens if we lift social distancing? Is there a second wave? Is there enough immunity at that time? Those are things that the system is modeling, but those aren't super well understood right now. So I'll give you some examples, I think, but the underreporting of tests versus confirmed cases, there is between different countries and how well people have tested. I believe one of the Nordic countries this morning, I think it was Iceland, or perhaps it was Iceland, that reported that they have been testing generally people without symptoms as well, and they're seeing about 40-50% of people having it but not showing symptoms. So there's a wide variance across people in doing so, and factoring for that is pretty critical. So for example, if you look at this chart for the state of Minnesota, the blue line is what's reported as positive cases. But if you look at the estimation given the number of hospitalizations and other best sources of data, is that the expected true infected is actually a lot larger, and it's actually rising faster than our positively reported rate is. So that's a very critically important factor to know, because it tells you how far the disease and the spread has already progressed. And the second, because it also affects how much of the population would have developed immunity at a given point in time. The second thing that I think is very sensitive is I think the model does probably as good a job from a data standpoint as it can of understanding what the doubling rate is. But there's wide variance in the doubling rate, and there is interaction between the various reasons why doubling is happening. There can be at times super spreader events that can increase the rate of doubling suddenly. So, for example, in Massachusetts, a single company's event triggered 80 to 90 cases over the course of 2 days. But there also are other reasons why that can happen. So if you just look at, for example, the doubling rates have ranged from New York which till recently was doubling every 2 days. If you look at Georgia and California, they've been doubling about 4 days. To Washington, that's recently slowed down to doubling about every 6.5, 7 days. That makes a big difference. Now, a lot of this variance that is represented in the data is already being factored into by the model, but this is one of the reasons it's important to test the assumption with local knowledge as well. Lastly, I would talk about just the timing and effect of these interventions, especially around social distancing, is pretty critical as well. The most studied part of the social distancing so far comes from Wuhan. This is an example paper that studied the different times in which they enforced different levels of social distancing. The last level being extremely intensive and controlled, where your location's tracked, everything is shut down, all public transport shut down, all the city's cordoned off, no one can come inside and outside. And each of those phases had different rates of transmittability. So you can see in the initial phase was this first part of this curve where it was growing really rapidly. The second, when there was the first wave of intense sort of social distancing. But the third, which had high degrees of contact tracing, a very high degree of isolation, and a very high degree of sort of control, where it then started declining. The effective sort of rate of spread in those phases, the first one when they just limited non-essential travel and large gatherings, was pretty minimal. It was about a 1 or 2% effect. The second substantive reduction in contacts through social distancing was about a 35% reduction. And then the last one, which was contact tracing, every person is who has it, there's monitoring of the quarantine and such, that went significantly lower. And once that rate of transmission falls below 1, then it's no longer a pandemic because it will slowly die out, i.e. each person is no longer infecting more than one person, and therefore it doesn't exponentially grow, which it does in the original situation where it's every person is infecting about 4 people. So you can see how that multiplicatively 1 becomes 4, becomes 16, can grow really fast, but lowering that can have a big, big impact. So those are the 3 variables that make a difference. There's varying pieces of information around social distancing by state, how effective it's been, scores around the change in average mobility, and it's pretty apparent that in many places of the country that is having a substantive effect in terms of certainly mobility, infection rates. I think there's also information on the percent from a company around fevers being reported reducing. So we are factoring all of those into the model from a data standpoint, but just having, again, a local understanding of that will allow you to design the scenarios more appropriately as well. So let me pause here I think we had a quick poll at this point to just see, as you think about the different phases of this pandemic, phase 1 around planning for the surge, phase 2 around situational awareness of your critical resources, how do you make sure you're as real time as possible around that, third, creating capacity for them in the short term, and 4, sort of being prepared for the long term and the potential surges downstream. What's top of mind for you right now? So I'll let folks just take 10 seconds and then all right, I think it looks like there is probably the highest pieces of information. About 32% of the folks are right now focused on how to create capacity and how to manage the capacity for COVID-19 patients in the short term, following by how to plan for the surge of COVID patients, and the third piece being optimizing flow for creating capacity over the longer term. And very closely fourth is the situational awareness and the critical resources. So that's super helpful feedback. I want to then move into any Q&A around the planning model so far that has come through.
Yep, so we've had quite a few great questions come in. I think the first one we can take is, Mudit, this attendee asks, how do we access this modeling / prediction tool?
Yeah, so if you, there was a link earlier. If you go to Qventus.com, you should be able to navigate to that. The specific link for that, let me just go back to it and reshare it, was in the presentation as well, and I'll share that in a second. The specific URL is Qventus.com/COVID-19-model. So if you have that, you should be able to access it.
Excellent. Thanks for pointing that out. The next question we will take is, this attendee asks, can I share this model with others in my system?
Yeah, absolutely. There is a link on the top right that you can use to share the model with others. You can also, if you modify any assumptions, that URL will also allow you to share the modified assumptions model with others in your system as well, and please do so.
Great, thank you. And we'll take one more before you get back to the rest of the presentation. So this attendee asks, how often is the model updated?
The model is updating as frequently as data sources are coming in, but typically about once a day. So for example, case counts are coming in about once a day. Hospitalization rates across probably about half the states are coming in about once a day. So once a day, the model is refitting based on the data that's is happening in every local area. We are also, as new research is coming out, have been updating the model fairly frequently from that standpoint as well, to give you the latest and greatest at every point in time. And I think from that standpoint, I'd say over the last 7 to 8 days, there have been 3 meaningful releases of the model already, given the amount of new data that's coming out. I see one other question about how it is different than an SIR model that might be relevant to answer as well, which is, this is an SEIR model, which is includes an exposed period in between to make sure that the incubation time of this disease is factored in. The second thing that is very different is that how it's initialized using local factors and how it's updated is different, but it is the same basic mechanistic concept as an SIR model would have, but more tailored to COVID-19.
Well, thank you for tackling all those, and definitely appreciate everyone's participation there. Amanda, I think if you want to carry on with the rest of the presentation, that'd be a perfect time for that.
Yep. So let me then share a bit about how partners are now then thinking about preparing for capacity. And I will say there are 2 aspects of it. I'm going to focus a bit more on creating virtual capacity, but certainly there is a lot of work ongoing on first from a surge planning standpoint, thinking about how do you staff in this situation? How do you create capacity from that standpoint? What other ambulatory surgery centers, what other locations, what other types of beds can be converted and used as what I would call phase 2 surge? And
also planning from a standpoint of a phase 3 surge, i.e. what happens if we were to completely run out of capacity. And in that scenario, it's beds in hallways, it's alternative sites, it's a kind of a situation that's completely out of the physical and staffable capacity. So that's one aspect of creating capacity. The second, though, is pretty critical, is around how do you manage and create virtual capacity given the staffing constraints in this environment. So I'll share a little bit about how people are using the time that is available today to activate capabilities that will allow them to free up capacity, both from the COVID-19 patients, but actually even more importantly, from the remaining 50, 60, 70% of patients in the hospital that are non-COVID as well, to make sure that it's sufficient capacity as much as feasible for the COVID patients. So the short-term solutions will focus on those aspects. How do you create ability to rapidly adapt, since the disease is hard to predict? How do you adapt very quickly? How do you manage the ICU and ventilator capacity? How do you manage the med-surg capacity and ancillary capacity along the side? So I'll share those, then we'll talk a little bit about what do we do to be better prepared from a long-term standpoint as well. So first, I would say that the solution design approach that we found effective with our partners in this time is all of your systems are under a tremendous strain right now, especially the front lines. It is pretty well recognized that as we work to flatten the curve, the strong predictive planning and creating virtual capacity will be critical, but we have to balance how to do that in an environment where there is just a lot going on in each of these systems. So the way most systems have thought about it is to break into phases. The immediate term planning needs to be done, short-term intervention over the course of the next week to 2 weeks, long-term transformations that are probably in the middle of the summertime if this does have a lull, so that we can prepare for the long term. That's sort of how different things have been thought through with our partners so far. And I'd encourage the same, so that you have a sense of, you're not just solving the immediate term, but you also have a sense of when you will have the right time to do each of these pieces specifically as well. The key design points have been, where possible, start with capabilities that can be live quickly, trying to have as minimal of a frontline team impact and time impact as possible, low IT effort, and in general, just time's of the essence, just working with high degrees of trust across the board in the collaboration. That's how we've designed solutions in this phase. The short-term and centralized, so typically right now, one of the things that folks are trying to find out is, especially when the frontline teams are going to be extremely busy, how do we create centralized situational awareness into resources that might be running out, both for purposes of awareness, but also for purposes of rapid load balancing? How do you create mechanisms of relieving ICU pressure? And again, looking at that both across in facility, but across facilities, and prioritizing key patients for step down. Similarly, looking at med-surg patients and trying to understand what barriers are coming through. So, for example, one of the things that we've noticed is that a lot of COVID patients, post-acute placements have been hard, and how do we anticipate barriers like that in advance? Second is, even this, I think it was the CDC that had some guidance around patients that might typically stay for periods due to non-clinical reasons, social needs, operational delays, and other reasons. We have to find ways of defraying that capacity and creating solutions for that pretty actively as well. So that's the short-term pieces. I would say in short-term, these solutions tend to be more centralized to minimize any impact on the frontline teams from the standpoint of what work that is needed of them, given all that is happening already. The long-term and decentralized in the long term, to make it sustainable, we can't continue sort of the heroic efforts that are going on if this lasts a long time. How do you create that capacity creation so that that is hardwired? And for that to be hardwired and in the habits of people, that has to be spread and the front lines, and has to be distributed. So we'll talk a little bit about that. So those are different solutions in each phases that we're working with customers on. The first piece is how to integrate the today with what's likely to come. So the first piece of that is driving and as reliable a set of surge planning as possible through having real-time situational awareness at multiple altitudes, facilities, units, multiple facilities, system, region, and especially on key resources like ICUs or negative airflow isolation rooms or ventilators and being able to manage them. So for example, if we are seeing negative airflow isolation rooms running out and you're using them for your PUIs, and we see, or for sometimes for a broader set of isolation patients, and one of the things the system is observing for one of the health systems where the curve isn't as far along is patients who are on negative airflow isolation rooms but don't have a droplet or an airborne isolation order and seem likely to be able to discharge soon, and highlighting those. So that kind of critical resource visibility across the board, across one or multiple facilities, is critical. The second is then integrating from real-time hospital data, all of those into the planning tool that I was showing you before, to integrate bidirectionally. One direction is to go and have the live census and the live understanding of COVID demand and all of that back into the tool for your health systems, but then the output of that back into your sort of mission control and system command center as well. And the third piece that is pretty critical here as well is making sure that when we have to adapt to the situation, we have to adapt very quickly. So how do you create rapid ability to put into place plays that you have to execute from your surge playbook? So we have a set of automated real-time nudges that both predict constraints but actually create specific conversations across different groups on how to resolve and load balance those. So for example, if you see one region having low demand, then the other, creating that awareness and what needs to happen in that situation. Another example for a health system is they've created a specific hospital where most of the COVID patients are going. When we see that it's likely that in the next 7 days you'll run out of that capacity, initiating automatically a nudge for a discussion around preparing a second location or a fully distributed model. So things like that, and I think that's the first set of capabilities. The first version of that was live in about 4 or 5 days. I think it was on March 5th to March 12th, roughly speaking. So that's a fairly quick capability, but having both the situational awareness, but more importantly, the bidirectional sort of demand and input into the demand models. And lastly, this mechanism of creating hardwired automated surge plan predictions is super critical in this case. So that's the first piece we found folks have found really helpful to have and to make sure they can manage the chaos as and when it comes. The second is to create ICU capacity through step-down review. So again, in typical times, we've seen that about a third of the ICU patients are ready to go and step down at least 8 to 12 hours prior to the transfer order is written, or even if the transfer order is written, it often takes time for that to actually go through. But also in times of this stress, the ability for frontline teams to continue engage in this is going to be even harder. So creating a central view into ICU capacity, and more importantly into candidates that are most likely to be ready for step down, is super critical. And it's very, very hard to do normally. So what we've done is built a machine learning driven prioritization list that has had that uses medication data, ventilation data, lab results, intensity of service data to look at which patients are highly likely to be ready to be transferred out of the ICU into a med surg unit or a step down unit. And what is happening here is when ICU capacity is short is when this is getting teed up automatically for review by a centralized team or a physician or two. And it's a very, very targeted list to if they can move, making sure that those patients are moving, and if they cannot move, then identifying what barriers might exist that can actually help do that. So if you think about it, this is super critical. If a similar ratio of 33% of the patients being able to be discharged earlier is feasible, that's often more than the surge capacity that is easily available in other mechanisms. So compared to opening up more or converting more beds into ICU beds, that creates pretty significant capacity from your existing units and from your existing beds without needing additional staff. So that's one that has been very beneficial and very important for customers as well. This one is a very new capability, and we're continually tuning and improving it as well, but that's been a big ask across the institutions as well. The third one is creating staff capacity through discharge optimization. As I was stating before, you both need staff and beds for existing patients. You need them for PUIs. You need them for COVID patients. And the traditional discharge planning processes and inputs from staff in this case may suffer. So creating in this case, a centralized machine learning driven continuous orchestration of discharge planning has been valuable. So the first piece of that is looking at every patient, identifying that this patient, for example, let's say it's a non-COVID patient, was on a NPO, is now on a liquid diet, and the solid diet order just came in, and it's seemingly progressing. Their IV medications are reducing, and based on all this, we believe this patient could go home fairly quickly. But not only that, using some probabilistic inference models to say, while there's a high chance this patient might leave in the next 36 hours, our likelihood, given it's a Saturday and given how loaded the MRI department right now is and the asks on them, that we are able to prioritize this patient's MRI is not high. So we need to first surface this centrally, and if agreed upon, then make sure that the communication goes to the MRI department to prioritize this. So that sort of upstream prediction of the barriers, predictions of dispositions that this patient may need a sniff, especially very valuable for patients on COVID and otherwise, allow for an upstream discharge planning to be possible in institutions and to be allowing this to happen centrally as well. The third piece of that is anticipating ancillary needs. So if you start seeing a lot of gaps where MRIs are starting to become a barrier, then that allows you to understand where the bottlenecks are going to end up coming through in your organizations, and to make sure that those bottlenecks are being proactively managed as well, not just at an individual case or individual patient level, but systematically both across the facility, but also across a system if needed. So if there is certain kinds of staffing challenges that are preventing sufficient RT capacity, what can we do from that standpoint? So that's the third variable. There is a fourth one, I would say, which is later down the line, probably not in the short-term considerations, but in somewhere in the mid-term considerations, which is around managing ancillary capacity by predicting where, for example, MRI or CT orders could be defrayed to outpatient versus leaving them inpatient. So this is another set of tools that we're working with our current customers on, and if we have the data from the organizations that we could deploy as well. I think we've also worked with customers in trying to look at first of all, I think our first imperative is to flatten the curve as much as possible. But how much could virtual capacity freed up like this help in that situation? So as an illustration, if we limit the attack rate of the pandemic to about 25% and take an example, a hospital about 500 beds that typically has 70% occupancy, by reducing 12 hours of length of stay in the ICU, by reducing the med surge capacity about half a day, you can actually meaningfully shave off the capacity required for COVID-19 or the shortfall of the COVID-19 beds meaningfully by creating this virtual capacity through much, much more tightly managing the ICU, the med surge capacity, and looking at the key resources and ancillaries that are required in this phase as well. The The last piece I would share is around the long-term flow optimizations. I think this is much more similar to the work we've done historically with customers. This is, I think, the thinking for most organizations here is if there was to be a lull in the summer, or in general, if such future surges was to come, how we can't potentially keep running through heroic efforts all through this. How do we create systematic ways that make sure that such virtual capacity is always available to us? And some health systems have even referred to it as the hand washing of health systems, that these are things we should have always been doing, but we should do them even more today, and we should make sure we don't lose the habit. And it is hardwired as we go past the immediate surge of COVID-19 patients. So I won't go significantly into detail on that part, but the way that works is through a combination of the automation platform that uses behavior science for creating hardwiring that we have. The way that that is built is through behavior science principles around identifying issues, orchestrating actions, and managing accountability, which is very similar to all the behavior science research on a cue that reminds me to do something, making the right thing to do, the easy thing to do, and making sure there's accountability for me from a habit formation standpoint. So that technical infrastructure powers all of that. Specific solutions of how to hardwire that, operational practices, frontline coaching and such. Those are all the three pieces of the people, process, and technology that we would bring together when we want to hardwire this less centrally, but more in a distributed long-term fashion. So that we're also planning for prospects with that for a midsummer time frame to do this so that we are best prepared for the fall piece of it as well. The way that would work differently is that similar kind of intelligence is then distributed much more on the front lines on each unit. And there is frontline clinical variation during MDRs that happens that triggers automated orchestration. There is deep measurement of process fidelity and process compliance. All of that happens in an automated fashion across the organization and creates this mechanism of a highly coordinated flow of patients that is beneficial in all situations, that allows you to shift it into high gear anytime such a need was needed as well. So that's, I think, the piece there. We've seen significant success in that piece as well. But to just sort of build all of that together, I think the first piece that we are seeing health systems look at is the first key need is the localized planner that we shared with you today. That's the tool that we made pro bono. It's free. Anyone can go to the website and use it. There's no hospital IT lift. You can start using it right away. That allows you to get a sense of where things are going. The second is this critical resource mission control center where we have the demand planning inputted and the inputs of the real-time data feeding back into the localized scenario planner as well. That is a very low lift. It's typically could go live within about 6 to 7 days, at least in the experience so far, and it allows for hardwiring the surge plan that you have as well. I say that the phase after that is around capacity creation, the virtual capacity creation. Probably about a moderate lift. That's about 2 to 3 weeks for initial capabilities to be live and to be available. And then I think the full solution distributed piece is probably 3 to 4 months away. There's some meaningful lift there to get full amounts of data and such, but all the work in the first 3 phases tees up that fairly easily as well. And that's how, from a capacity standpoint, organizations have been thinking about it. And we've seen really good success. While this COVID-19 is very new, the principles of applying capacity management, creating virtual capacity, we've seen great success with that historically as well, through organizations creating between 30 to 40 beds, a hospital of additional capacity virtually without needing additional staff by using these AI-driven habit formation methods across a whole bunch of organizations across the country. So let me actually pause here, both for a quick poll and then answering further questions that folks might have. So I think maybe given this, I would love feedback. We've had probably 40 to 50 conversations in the last 10 days with organizations around this and implemented it at a bunch of places. But given your systems and your hospital's current situation, what of these capabilities would be most valuable to you, and where would you suggest we continue to invest more resources into as well? So the first being the COVID surge planning, the second being the real-time visibility into med surge beds, ICU beds, and managing the hardwiring of demand planning and your surge planning into that. The ICU step-down capacity, machine learning, the med surge capacity, probabilistic inference model, and the last being the longer-term capacity creation through length of stay optimization. So I'd love to give folks 10, 15 seconds for doing so. And I think we saw some questions come in the meantime, so we'll start reviewing those and preparing which ones we can answer right away. So I see, I think from right now, the response is what's most top of mind for folks right now is the COVID surge planning and the real-time visibility of the demand planning and the situational awareness together. So about 45 and 35% of people respectively talked about that, followed by how to manage pretty equally, how to manage ICU and med surge capacity. And I think understandably right now, the longer term is less on top of mind for people, given everything else going on. So it seems it was mostly in the phase ordering that we shared. I think for people, the first phase is probably most top of mind, and the second phase followed by that, third phase followed by that, and the fourth after that. So that's super helpful feedback. Maybe, Brian, should we take questions then?
Yeah, I think that's a great time for that. And just as a reminder to everyone, you can type any questions you might have into the Q&A tab down there at the bottom of your screen. And the first question we'll take here, I think it's especially pertinent considering the urgency of the moment. The attendee asked, what has been the fastest go live once the contract is signed? So what has been the fastest go live once the contract is signed?
Yeah, I think our first one was, I think it was Friday of the 5th of March, and I think we had the first version live on the 8th of March. Now it's a very cooperative team on both sides and a lot of weekend work. But that was about 3 to 4 days for the first capabilities in the Mission Control Center to be live. I think the rest of it, we have now some fairly streamlined sort of data and other pieces as well, but that's the fastest, I would say, on the critical mission control piece of it.
Great. So the next question we have here is the attendee wonders, is this free of charge and ready to use?
Yeah. So the COVID local demand planning tool is free of charge and ready to use. That we made completely free. The other solutions I talked about do require some infrastructure above and beyond for us and data that is specific to a hospital. That we are doing at for our current customers, large portions that we are doing free of cost. For new customers, we'll have to have some formal agreement in that case, but it'll be at a reduced cost as well.
Great, thank you for that. And there's, I think, a lot of concern out there around timelines here. So the next question we have here is there really enough time to deploy new solutions?
Yeah, that's a really good question. And I think that answer is very local driven. I think for most organizations, like if you were in New York, probably not at this point in time. I think for most of the other organizations right now, what we are hearing is from their standpoint, we still have about a week or 2 weeks of time where we can create capabilities that can save a tremendous amount of time and energy downstream. The second is, I think certain sets of capabilities for them are being prioritized more from a point of view of, if we do have a second peak, what do we do today so we can plan sort of the right initiatives today, as and when we get a lull, to be able to activate those so we can be well prepared downstream. But that's a fair concern. I think that answer is very locally driven, depending on how far along the curve are you already. And if you're not, I think depending on the amount of time you have, there is certainly time to deploy some capabilities, and we'll have to have a conversation on which ones might be most beneficial in that case.
That makes sense. And I think the next question here sort of fits into this conversation around longer term strategy. So this attendee asked, how do you manage aftershocks to the initial COVID outbreak and subsequent outbreaks?
Yeah, there's many things related to that. I think we shared one aspect of that is to create the virtual capacity, because if you think about it, there is a follow-on peak of this. We will be in a situation where there would be already have been about 3 to 6 months of intense activity across the delivery system. So how do you create virtual capacity right now so that at that point in time, it doesn't again require heroic efforts? I think that's one big piece from our standpoint. Certainly creating other mechanisms, which I think many organizations have done, of creating other mechanisms of access to the system digitally is another important piece to have in place prior to future outbreaks as well. And lastly, I think continually, this is kind of a preparedness piece now, where having the ability to rapidly create situational awareness and rapidly be able to understand what peak resources might be needed, even if there was a different kind of a pandemic to come. I think these same principles should hopefully extend there, but just making sure that we are applying them systematically and not through cheerleading would be super critical.
Great, thanks for laying that out there. And the next question we'll take, I think I'll give you the chance to reiterate some information here. I'm going to pair two audience questions together. So the first one, the attendee asked, where do we get the free tool? And the second question, the attendee asked, how long will the planning tool be available to end users?
I think the free tool question we had answered. It's on the website. We can share the link one more time. How long is the tool going to be available? Candidly, as of right now, we haven't thought of any reason to make it unavailable, so it will be available as long as it's relevant and beneficial to users. And hopefully it's not needed for too long for all of our sakes, but it will be available and it will be free. It will not be that is not a tool that we would modify and take away access for.
Well, thank you so much for taking all those attendee questions. And Madhu, do you have any final thoughts to share with attendees today?
Yeah, I would say it's first of all, thank you for taking the time in this time. I think it's pretty uncharacteristic, uncharted time for all of us, and it's a tricky balance for us as organizations and people to both balance and create the benefits short term and figure out how to do things so that we are well prepared long term. The balance of just solving it by muscling through it versus solving it systematically. And I think my hope is, if nothing else, but thinking and breaking down thinking into what is needed short term, what is needed medium term, and what is needed long term, and writing those down and really thinking through the different phases and what you will need in each of those phases is still very, very valuable to each of your organizations in this time that is fairly turbulent. And while we don't know the answer of where exactly things will go, the ability to have some sort of a plan around that and the ability to have capabilities that allow you to navigate each of those situations is pretty critical. And in particular, given the unknowns in this disease, I think it's pretty critical to have an ability to in real time adapt to what the new patterns are showing. And that's sort of how the planning tool is built. The ability to adapt operationally to see where resources are and where things are changing, and the ability to create capacity on an ongoing basis. So those are three lessons for us that have been valuable across the organizations, and I hope those are helpful to you as well.
Well, thank you so much for sharing all those insights with us today. And thank you, Qventus, for sponsoring today's webinar. I also want to thank all of you for joining us during this challenging time, and we're wishing you all the best. I hope the rest of your day goes well. Thank you.
Thank you.